Welcome to the Women's Health Podcast. I'm Marika Hart from Hemisphere.
And I'm Anthony Lowe, the Physio Detective. Together we interview leading authorities, answer questions and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember that our materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis or treatment. Now it's time to get cracking with the episode. So whether you're out walking your dog, driving the kids to school or just sitting back enjoying a glass of wine, we hope you enjoy the show.
Hey everybody, thanks for joining us for another episode of the Women's Health Podcast. And we've got Gráinne Donnelly from Absolute Physio in Northern Ireland and Marika Hart from Hemisphere, Dynamic Strength Physio in Perth. And we've got Elaine Stevenson, who's helping to take the show notes and compile the information for us, who's helping us out from Myotherapy Reading Room. So Grainne, tell us a little bit about yourself and where your passions are, and ease us into this topic of diastasis and what you'd love to get out there as a message.
Okay, so thanks for introducing me, Anthony. I'm Gráinne Donnelly. I'm a physiotherapist working in both private practice and the National Health Service over here in Northern Ireland. So I'm actually the advanced physiotherapist and team lead for my local health trust, and I work alongside my physiotherapist husband in our private clinic. My big passion is pelvic health, and that's all things pelvic health, from pelvic floor, abdominal muscles, post-natal. And along with that, diastasis is a huge topic. I got interested in it about 8 to 10 years ago when I was fascinated by clients coming in complaining of a weak core and this mommy tummy, and I suppose the medical world didn't seem to really acknowledge it or understand it. And when I went searching about it, there was very little in terms of research out there. Thankfully, we're a wee bit further on, but we have a lot of work to do in it. And what the main message that I want to get out there is physiotherapists have a role to play in diastasis, and we need to, I suppose, increase our voice in terms of that.
That's great. That's great. I totally agree. We definitely need to make our mark out there, and we have so much to offer. What are some of the common characteristics, or what are some of the common themes that you're hearing from clients that you wish they could have before they come in to see you, and things that could get clarified before they even come in and see us to find out about what we can do?
Just even on more understanding of what diastasis is, it's quite a fearful condition for many women when they don't understand that, I suppose, some degree of separation is absolutely normal in pregnancy. So I think we need to increase our awareness and start to break the fear and, I suppose, misinformation that's out there. I suppose the diastasis basically is separation of the rectus abdominis muscle bellies, and so that's the six-pack muscles that go down our abdomen. Some of us have more definition than others, but the linea alba is the connective tissue in the center of that, and during pregnancy, that's there for a reason. Some degree of give is absolutely normal in it, and it's been demonstrated in the research that 100% of women do demonstrate diastasis at 35 weeks gestation. However, it's only really an issue if it doesn't resolve and if it's significant enough to compromise the function of the abdominal wall.
Awesome, thank you. Sorry, I took a little bit of a time to unmute myself last time, and Anthony he's quicker off the mark than me. I just wanted to ask Gráinne, I get a lot of people who self-refer, and sometimes they do have really significant diastases, and I can pretty much put my whole hand in there, and they will have quite a lot of functional deficits as a result of that. But I will also get women who will come in who literally have like maybe one finger separation, and they're terrified of this and they think it's abnormal. So I guess I have two questions, if you don't mind answering these ones. Is do you find most people are self-referring to you, or are they coming via other means? And how do you describe, how would I say, how do you know if a diastasis is sort of significant enough to warrant treatment?
Okay. Well, first of all, yes, many of the women who come self-refer, both NHS and private, it seems to be the women flagging this up to their care providers in order to get referred. It still, to me, is something that isn't established enough within our medical system for people to be getting screened and the health professional identifying it. So many women, because of the wonderful thing that's the internet, it's both wonderful and it can be a detriment, but because of the internet, many women are figuring out they have it and asking for a referral. In terms of what's significant, that's a great question, and a question I still think we have a lot of work to do on, because we still have quite a lack of consensus about what is diastasis, how do you diagnose it in terms of parameters. However, my experience would be that it's not just about the gap, as I hope we're all starting to realize. It's about a lot more than that. And really, it's about the function of the abdominal wall and the tension across that linea alba. So to me, if someone has a separation, but they're able to transfer a load across the linea alba without doming or sinking or sort of compensatory strategies that aren't anyway, I suppose, negative to what they're doing, I don't think that's necessarily significant. But like you, I get a lot of women with less than a finger width gap coming in, and they're obsessing over the gap and they're feeling it regularly. Again, I think a lot of that comes down to beliefs behind diastasis and the association with aesthetics, because they think that if they have this one finger with separation, that they're going to have, I suppose, a mommy tummy or develop a mommy tummy. So I think that that's a huge thing, and we think we need to be really getting better information out there in terms of that.
I think that's a really good point, because I do think sort of 10 years ago, most of us weren't even talking about diastasis, right? Like, I certainly wasn't. Maybe we covered it in undergrad. I don't actually remember. I certainly didn't cover it in postgraduate studies in the musculoskeletal physio world. And I think we've sort of, well, I myself, and Grainne, I'd love to hear your journey with diastasis, but I kind of went from being ignorant about it to being, oh my God, how did I not know about this? I have to fix everyone and it's a disaster. You know what I mean? And then I've kind of come back to that sort of middle ground where it's like, calm down. It's actually, most people function with a small diastasis, and like you say, if they're loading well and there's no bulging, and they're able to function and do the things that they want to do. So I kind of feel like I've been on this bit of a journey of like ignorance and then catastrophization and then coming back in the middle somewhere. Can you tell us a little bit about your journey with diastasis and how you first heard about it and where you went from?
Yes, well, I've been on quite a journey too, Marika. I think everybody has with diastasis, and certainly everybody should have, because there was no research out there, and the research has bit by bit trickled through. When I started Googling diastasis, first of all, nobody local to me knew anything about it. They knew what the terminology diastasis recti meant, but it was just something that women got, and that was part of pregnancy, and that was it. So I started to, as I say, research it a bit myself. And this is where my bugbear comes in, because I think as physiotherapists, we need to step up a bit more and increase our game, because we know, Marika, I follow yous, I know that yous know that we have a huge role to play with these clients. However, when I was Googling, it wasn't so much physiotherapy coming up in the top of the rankings. It was very much programs and prescriptive programs, like I'm sure you've heard of the Tupler technique. We went over to New York, and I actually trained with Julie Tupler, which was the starting point of, I suppose, my diastasis journey, and something that I don't regret, because it really opened the floodgates to referrals, which is a wee bit sad to say, that as physiotherapists, people aren't finding us. First of all, they're Googling, they're finding online programs, they're contacting experts, or they're contacting key people who they're following across the world, who's then signposting them to me. And that was a huge eye-opener to me, because we need to be doing more. Like, I was there, I was a physiotherapist, I have lots of skills to offer. People should have been finding me anyway. So my experience
connection on the other side.
I know, but it was just the fact that gave me the opportunity to see quite a consistent caseload of diastasis referrals at a time when diastasis wasn't really that I suppose, accepted or something that was being referred to physiotherapy that often. So I got a lot of experience with these clients and was able to develop my skills and start to see correlations and findings that I was finding consistently happening with these clients. And then basically, Marika, me and you have talked before in the past about Diane Lee and how she's been a wonderful researcher and influencer in the diastasis world. And I think at one stage you were talking about organising a course somewhere with her, and I was like, keep me informed.
Oh my gosh, we were going to all fly to Vancouver.
Yeah, we were all thinking to do that. So she came to London a couple of summers ago, and I went over and did her course there. And again, it was wonderful because it's her research that has really transformed and progressed how we think about diastasis, in terms of it not being about the gap and about there being much more considerations in terms of the tension of the linea alba and the depth of it. So and what I'm doing now is, hopefully this time next year, I will be undertaking my own small-scale feasibility study as part of my master's to investigate, I suppose, the impact of low-pressure fitness or hyperpressives versus conventional rehab. We have to decide what conventional rehab is. It's very hard to do a research study when I tend to individualize my treatment for every client. So how do you then do a standard prescriptive? Oh, that's going to stress me out, but we're going to do it, and hopefully it will provide us some information. Is low pressure fitness a big thing where you are?
I think most of us are aware of it, but I don't know about you, Anthony. I don't know many people in Perth that do it.
There's one person in Sydney that I know of that's affiliated with, I don't know if it's low pressure fitness or hyperpressives, or, you know, because there was this whole branch off thing. But yeah, there's not.
Oh, they're different. I assume they were the same.
They're the same.
So
but
the same
different
technique, more or less. They're just two different
organizations.
So do you use low pressure fitness?
No,
Okay, so
no, I've no awareness of it at all. I'm not a trainer. I don't use it at all. I have attended, we've had an in-service, or like we've had a speaker from Low Pressure Fitness come to our Obstetric and Gynae clinical interest group. It's something that makes huge claims. It fixes everything in terms of women's health. There's no need for women's health if you do low pressure fitness. So it intrigued me because when I started to look into it, there was no research. So I had to do a study. I thought that'd be quite interesting. So it's more just out of pure interest to see what it has to offer. So I won't be doing anything to do with the hyperpressive arm of it. I will have a hyperpressive teacher doing that. Figure out my physiotherapy arm and how we make it reflect as it should.
Yeah, I did a podcast, a different podcast with Trista Zinn from Low Pressure Fitness in the UK, and in Canada, sorry, not UK. So that might be something worthwhile looking up if you're interested in the low pressure fitness side of things. And we were talking about a whole bunch of concepts, but certainly it seems like different groups make different sorts of claims depending on who you're speaking to, and you know, there's a lot that we could talk about and go down the rabbit hole in. But you know, what I'm interested in is in that time, you see, so my history was that I was fortunate enough to have Diane Lee come out in 2005. I went to her Adelaide course, to be honest, and they, her and LJ Lee had put out basically a postpartum program. It's very, very old now if you go have a look at it, but you know, I remember 2007, around that time, doing something with it. So, and you know, diastasis was a part of both because of the transversus abdominis and all the core works side of things. So, for me, it's been a long time dealing with this, and it's hard because, you know, after so long, you get kind of, it's diastasis. It's very, very important to the people that are having it, and I never minimize what they're going through. But from all the kerfuffle that's going on, you know, it's an interesting thing. How are you finding it now that you've, you know, gone through? It's been quite a few years that you've no doubt been dealing with it. How are you finding as a physio compared to seeing what's going on in the world? How are you finding that mix going? I'm not sure if I'm asking my question clearly.
Well,
I'm not sure if you're asking that question well, Anthony.
do you mean in terms of the fitness industry? And I suppose, is that what you mean? No.
I think, you know, when you first learn about something, it's like, oh my God, here is a nail and I have a hammer and everything is a nail. You've been through it for a while now. How are you finding dealing with, you know, social media, fitness industry, even physios? You know, how are you finding navigating all of that in the big scheme of things? How are you finding the relevance and your own personal feelings about the topic? Because I'm sure we're going to hit peak diastasis, and then there's going to be diastasis fatigue and apathy, and
I've got
you know what I mean.
I think that, well, it's still a huge passion of mine, I suppose. I haven't got bored or sick of it yet, I suppose, because I feel like I've been constantly learning and developing, I suppose, what I do with it. I would do a lot of teaching of other professionals here in terms of diastasis, and that's what I enjoy, because I feel that a lot of people don't know what to do with it. It scares a lot of people. And then with that, you get inconsistencies of approaches, which is, if anything's going to induce fear in the population, it's when everyone's saying different things or doing different things. In terms of women, I like the fact that people are more aware of it than they were so many years ago. And I like the fact that people are coming in a little more informed about it. And I'm not the first person to tell them things, because, again, language is so important. And that's a huge issue I have with social media at present, because you get so many blogs and stories and writings out there that are talking about abdominal muscles being, I suppose, torn apart or ripped, and it's very fear-inducing language. And I think, similar to how we manage pain, we need to be addressing diastasis in the same sort of way. We all have those muscles. We all have that connective tissue. It's no different than any other area of the body that can have variations in how it presents. And we know, well, you're going down the pelvic health line, aren't you, Marika? Like, you're doing your master's? Yeah. Yeah.
Yes, I am.
Because if we think about other conditions that are to do with connective tissue and laxity, we only have to think of pelvic organ prolapse, which is something women are very predisposed to. And yet there doesn't fear more accepted in a way that that's something that can happen.
Interesting. I don't know, actually, because I think I'm just in a few Facebook groups at the moment where I actually see a lot of fear around prolapse.
Okay.
Yeah, no, it's an interesting point. I'll think about that a bit more.
Yeah, I do think that women obviously don't want to get it, but I think that they're more aware of the fact that they can get it. It's a more understood topic, if you know what I mean.
Yeah, maybe.
But what's your thoughts in terms of diastasis, Anthony? What were you kind of getting at in terms of how you find it out there?
I think too much is made of all the negative connotations of it, you know. I used to be very, very TA focused and very much about not just attention, but and not just the transfer, load transfer across the linea alba. This is something that's happened for a while for me, but just that people seem to put rules that just don't make sense to me. Like, you can carry your baby, but you're not allowed to do a sit-up. Forever, you can never sit up straight in bed, but you've got to roll onto your side. You know, you can't squat all the way down. You have to do a half squat. Like, there's all these arbitrary rules that don't make sense to me that people say. And you know, I really feel for the average client out there who comes into this and they're going to get extremes of, it doesn't matter, to, oh my God, be careful because your guts are going to spill out, you know. and I listen to my clients, and they are scared of things like that because they think that their internal organs are now vulnerable to the outside world. And I think that's a bit unfair. I think, yeah. And, you know, definitely there's softness and you can feel it. If your kid knees you or kicks you in the guts, you're going to feel it. That's for sure. But, yeah, why is everything
But
so extreme? That's what I want to know.
I think we are, as health and fitness professionals, adding to a lot of that confusion as well, though. I mean, we only have to look at, you know, a discussion we had a couple of days ago where someone's like, you know, why you should never do TA exercises because that's going to separate the abdominal muscles. And, you know, the research shows that, you know, doing a curl up will actually bring the two sides of the six-pack muscles together, and that's the best. And it's like, well, hang on. You're taking a massive leap there. When you do a curl up, of course the abdominal wall comes together. That's how we test for it. But that does not mean doing that as an exercise is necessarily going to make the linear alba miraculously shrink back together. And I'd be interested, actually, Grainne, in your thoughts about, because, you know, we will sometimes see in social media, people will say, oh, I have this great program and all my clients go from having a 4 or 5 finger gap to having 0 or 1 finger gap within 3 weeks. And in my mind, I'm like, that's just not physiologically like possible unless you're really early postnatal, in which case, yes. I mean, don't get me wrong, we get huge changes in our clients, but I sometimes wonder what it is these programs.
How are you measuring it? Like, are you measuring, okay, I measured you at rest and your 5 fingers, and now when you do a curl up, you're at 1, and before you weren't. Woo! You know what I mean? Like,
yeah. That's the huge issue, because that's the issue in the research that does exist as well, because everybody's measuring differently. And for me, we need to be measuring them where the muscles are at rest, because that's where people, I suppose that's where their linea alba is when people are walking around all day. You know what I mean? Nobody walks around in a full-on crunch. But that's the thing. A lot of women postnatal, as you know, you may initially assess them and there's a slow reaction or even engagement for the rectus muscle bellies to come in, and it may not come in that far, but you start to initiate rehab and the next time you assess them, it does come in much different. So I would speculate that a lot of those fitness professionals are assessing in a full-on crunch or even shoulders off the bed position, and getting that. Of course, the rectus muscles are going to come in quite well during that. I'm sure when they stand up, they still have the pendular abdomen and the lack of support.
Yeah. What's the standard measuring procedure for at rest in standing, right?
Yeah, I know. And that's one that Samantha Gillard's research really interested me. Did you see that, where she did find that the postural, that was, I think, published in 2017, was it? She demonstrated using ultrasound that the interrecti distance is naturally wider in more upright positions. So versus doing ultrasound at rest lying down, she did them standing up, and it was a naturally wider interrecti distance, which is really, really interesting and suggests that we're not, I suppose, assessing in the most functional way as physiotherapists.
Because of gravity on the internal organs, right?
Mm-hmm. Yeah. Yeah. But then that you could be getting a huge difference from what your resting measure is lying down to what really that client is having. But it's so hard to measure in that position. Like, it's so hard to be accurate even with ultrasound in standing.
Yeah, for sure. That would be, there's another research project for you.
Oh. Just a few more for you, Grainne.
No bother.
Sorry, I was just going to ask, what seems to me the biggest issue for clients, both online and in my clinic, when you scrape away everything else? For me, it tends to be, and I believe the research bears this out, it tends to be how the tummy looks. Are you getting that in Ireland as well?
Absolutely. The main reason people refer to me, self-refer, is not because they want to increase the function of their abdominal wall. They want to absolutely get rid of their mommy tummy and the aesthetics, and the research does back that up. There have been correlations, I suppose, highlighted strong correlations with body image and self-confidence in terms of diastasis. That is a huge factor. Although I do think coupled with that, like, I did actually a video a couple of years back with a client who's actually one of my best friends and colleagues, and she's a physiotherapist too. And she had her first baby, and she was your typical really small petite, really sporty. She would have had six-pack abs, and she had a diastasis afterwards. And yes, the aesthetics was a huge component, and it affected her body image. But she actually highlighted too her lack of frustration as someone who was really fit. She couldn't get her chin, she couldn't lift her head off the bed herself, you know, initially, and she knew she was gripping a lot with her neck muscles and trying to compensate with everything. So for me, she, coupled with the aesthetics of it, was actually the pure lack of strength and function. I think it's a huge issue, and it's one that frustrates me in terms of the clients. And I think that the message out there when people are Googling and when people are talking to medical community in terms of, I suppose, consultants, whether that's obstetrics or obstetricians, gynecologists, or whether that's plastic surgeons, is that their perspective is that diastasis is purely cosmetic, like, which really frustrates me. I don't know if you find that over in Australia, but I actually did an interview with several plastic surgeons throughout the UK and Ireland to find out a bit more and ask them the same questions. And 50% of them thought it was absolutely purely cosmetic, no role for physiotherapy. And the ones that did find a role for physiotherapy were actually quite engaging, but it turned out that one of them had done their sports medicine masters alongside physiotherapists and got their eyes wide open to what physiotherapists have to offer. So that was really interesting. But yeah, I think that when now we're getting publications in the I suppose surgery journals highlighting that there's functional implications with diastasis. So even within the plastic surgeons world, they're publishing journals and articles to say that once they did the recti application, women significantly improved their low back pain and urinary incontinence. However, there was a systematic review last year. It wasn't systematic review, it was just a literature review last year on plastic surgery articles, and it basically, I suppose, in black and white wrote that physiotherapy has no role to offer in diastasis recti, and that's because we don't have enough out there to
Well, I think
make our mark. We don't.
Yep, sorry, you cut out a little bit there. I think in that review as well, it's important to realize that their measurement of success was narrowing the gap. Instead of improving function and strength and return to normal activities, which is exactly what we do. And so from a plastic surgeon's point of view, they're going to get someone who's been through physio, feels a lot better, is a lot stronger, able to do absolutely everything, but doesn't have the diastasis closed to where whoever wants it to be is there. We can't do anything about the skin. I think I understand from that point of view. If you take that as a measurement of success, then yeah, physios can't be plastic surgeons, but we certainly can do physical therapy, and we can certainly help people, you know, not just physios, but other professionals as well, you know, get them back to being stronger, fitter, and help them navigate their way towards their goals, be it fitness goals, you know, personal ADL goals. These are really, really important for me. So yeah, that review annoyed me because lots of people who have a bias are just going to pick it up and say, "See, physio, no good," and it's like,
I know, but that's my thing. We're an uphill battle, and we need to really, I think, as a community of physiotherapists around the world, we need to have a more common voice, and we need to be putting things out there and having consistency in it, so that when people are searching stuff, they're getting that same message of, I suppose, good evidence-based message out there, so that they're starting to realize that we have a huge role to offer. And it's, I think, because as physiotherapists, we don't tend to be as selly, is what I would call it, in terms of we're not trying to say, you know what I mean, like, come and get your washboard abs back in 6 sessions. You know, we're not like car salespeople. But there's a lot of other professions that kind of cross into our industry that are doing that, I think that that's what we're up against. So we need to be better at championing what we do.
So Grainne, just on that note, could you talk a little bit about what physiotherapy looks like in terms of treatment for diastasis? So like someone walks in through the door and they've come to see you, they've got, let's say, a 3 to 4 finger gap. It's very soft in there. They're really struggling with going to the gym and lifting things. How does physiotherapy look different to, for instance, any other kind of management by a fitness professional, for example?
Well, it's a holistic approach from the offset. And I actually developed, I suppose, a performer that I used to teach other health and fitness professionals over here to give them something to work through. And I call it triple P RLD, or some posture patterns, respiration, rib cage load, and defect. So I work through them, first of all, getting that person's story. How long have they had diastasis? Who diagnosed it? Did they diagnose it? And what their, I suppose, intention with going to physio is, because that's where I establish whether that's something I can help them with, or whether they just want all their loose skin gone and so they need to see a plastic surgeon. And I think that's the first key thing to find out. In terms of posture, again, we can debate all day long about the likes of posture and the implications of it. However, certainly from a self-efficacy point of view and confidence issues, because we know diastasis has a huge correlation with body image, if I can improve someone's posture and improve their I suppose, confidence from the offset, I like to engage them from there, because they're already maybe leaving feeling a little bit better, which it gets them on board. Patterns, I like to think of how they're moving, how they're, I suppose, transferring, and how they're carrying out. And don't get too bogged down in terms of recruitment strategies such as muscles. You touched on that a little bit earlier, Anthony. I think there was an era where we really focused on certain muscles, recruiting certain orders. What I more concentrate on is, are they overly bracing, and have they got bad strategies in terms of breath holding and things to, I suppose, achieve extra strength, or how are they doing, what are they doing? So I'm looking basically at how they're carrying out normal transfers or normal tasks in their daily living. Rib cage, I'm not sure how much you focus on rib cage, Marika, but I tend to find a lot of women with diastasis flare quite significantly at the ribs, and they flare even more during the work of an activity in order to get that extra stability. Anthony, you might challenge me and tell me that's not a bad thing. I don't, but I tend to have a good look at that and see what we can do in terms of, because if the rib cage are significantly flared, we know that the rectus muscles attached to the rib cage at the top. So we want to make sure that if they're not a factor that's overly flaring out and, I suppose, encouraging diastasis. Load's a really important factor, and this is where I think we come into play as physiotherapists. We're exercise prescription specialists. I have really moved along over the last few years, and I'm huge into making sure we're prescribing the maximum load of activity that these women can have, and not being too safe and not being everything on their back and only doing, because a lot of women come with diastasis. These are crossfitters, they're high level sporting athletes, they're dying to get back to the sport that they love, and they have went to therapist after therapist and be told, you can't do that, you're not allowed to do this anymore, you'll never go back to CrossFit is bad. And that's what they want to do. So what we have to, it's our role to, I suppose, give them strategies to get back into that. And I've enjoyed watching Anthony with it's Mary Ryan, is it?
Lisa Ryan.
Lisa Ryan. I've enjoyed watching that story because I agree. I think that people should be able to get back to it. And I do tend to go on a guide of, I prescribe exercise in terms of trying to get them not to dome or tent, whereas you might challenge me on that, Anthony. Whereas I think that if we can maximally load it to a level that they can stabilize, you tend to progress from there, and you increase the load and increase the load and increase the load until they're back to normal activities.
I look like you.
Oh yeah, Marika.
I take it to just shy of that, but I have to be. I'm a lot more. I don't want to say assertive. Aggressive, like I load people up so much more now than 5 years ago, and it kind of came by accident. It was one of my clients who she was just coming to my normal classes, and we did lots of abdominal. We actually did quite a lot of abdominal work, and she actually emailed me later, and it was after her second baby, and she said, I was so much stronger after this pregnancy than I ever was before. And I remember kind of going, that's interesting, because I'd made my classes a lot less conservative. Maybe there's something in that, you know.
Mhm.
Yeah.
Funnily
Well,
enough.
So the
and I
amount of
did
women
have,
who come to me who can't,
sorry, you
sorry,
could,
Andy, because I was going to say a lot of women come to me who can't blow up a balloon, or if they do, they significantly dome. And like blowing up a balloon is I always think is a task that's normal life as a mom, because there's going to be parties at some stage. And I have so many women who come in with an absolute complex over the fact that it's nearly embarrassing, or they can't get their head around the fact I can't blow up a balloon. It's a simple task and I have to ask someone else to do that, and I want to be able to blow up a balloon. So I get people progressing to blowing up balloons, and balloons become a huge element of my rehab progression because it adds such a different dynamic to side planks and just normal exercises. It's really difficult. It gives I can feel the abdominal work when I'm doing it. So it's, if you can get someone blowing up a balloon with relatively good strategy, they're doing pretty good.
yeah. I was going to, I agree. You know, every time I blow up a balloon, I think, abs are working, and then what ways, and I want all the ways that they work. But you know, I did have a post, and I'm going to put a post. Lisa put a post of her and Erin Donato side by side, with me explaining why I'm okay with the visible tenting that you see with Lisa, and not okay with the not so obvious tenting that we see in Erin. And for me, it's you know, the bony landmarks. Like, how well do you keep within your bony landmarks? And when, you know, Lisa does a long hollow, yeah, she does tent up through the linea alba, but you can just push it straight back down, and then it kind of stays down. Like, it's not a real blowout type of pressure. Whereas when Erin did the same thing, because she'd only started doing it in the last 3 to 4 weeks after a long time, she just did not have the strength to maintain it. And her whole anterior abdominal wall was doming out. And, you know, I'm okay with Lisa doing her thing, but, you know, for Erin, it was like, well, you're not demonstrating to me what I need to see in terms of control and doing what you need to do to, like, she was really stretching on her tissues, whereas Lisa's got so much loose tissue that that you have to be aware that just looking at how it looks is not a good enough measure of whether it's suitable for her or not. Yeah, that was pretty cool to do side by side, you know.
Yeah, I seen that video, and that's one of the ones that then gets it. That's the type of thing that then throws the spanner in the works for me a wee bit, in a good way. But it gets me thinking, because then we have the age-old debate of whether diastasis and pelvic floor dysfunction are correlated, and we know that there has been, I suppose, conflicting publications in the literature, but more than not, publications would tend to say that there's the potential for some correlation, particularly with pelvic organ prolapse and diastasis. And that element of strategy that you talk about there starts to make me think, well, maybe that's a really safeguarding strategy, because, you know, if she tenses up a little bit, the pressure's not going somewhere else. Do you know, I start to kind of then think, right, well, what is it that we want to be happening? It just gets me. What do you think, Marika?
No, I'm only smiling because Anthony and I have had this conversation with before. You know, it's like, because some of the studies that show, I don't know, which was the study, Anthony, that showed that women who had diastasis had less pelvic organ prolapse at 12 months.
Oh, yeah.
So
Yeah.
2016-17.
What's the correlation? Is it a correlation? Obviously, it's a correlation, but is it a causation? Like, what's the relationship?
From a marketing point of view, we could say that those. So if we were pro diastasis being protective, you could say that it's nearly 4 times the rate of women without diastasis developing pelvic organ prolapse compared to those who had a diastasis. And so you think, wow, but we're talking about 4% and like 4.5% and 16% or something. You know what I mean? Like, and so then if you're negative on that and you think that diastasis is linked to pelvic floor dysfunction, then you'd look at the studies and say, well, it's still really low and we don't really know what happens. Like, no matter which position that you take on your beliefs about diastasis and pelvic floor dysfunction, you'll find some way to work around whatever it is. For me, it's just like throw the spanner in the works and see what happens, right?
Well,
I
I
guess
really hope.
always treat that individual that walks in through the door, right?
Yeah.
Yeah. And I think women, the population we're treating with diastasis are high risk of pelvic floor dysfunction anyway. You know, they could have easily just been coming in with pelvic floor dysfunction. These women who are having babies, that's our risk factors. But I really hope that Carrie is doing a longitudinal study on that, or following that up, because I'd be really interested to see if exposure over a longer period of time changes those outcomes. And again, they're all primiparous women. There's things that you could flag up to say that it's too early to know in terms of that study, but we're never going to have a study that completely gives us the answer that we want, because we cannot control all the other factors, and that's just the long and short of it. So there's always going to be a question. In terms of what I see, and I use a lot of ultrasound, I would use ultrasound both abdominally and transperineal, and I do see implications for the pelvic floor, but then that's maybe my bias. I treat the pelvic floor a lot too. But I would see that there can be a lot of descending at the pelvic floor and excessive pressure due to the way they compensate. But then again, the limitation of that is that I'm assessing them crook-lying, which probably isn't that functional compared to what they're doing in their day-to-day life. So yes, you could challenge that, Anthony.
No, I never challenge what people observe, right? It's just the stories we put around it and the meaning that we put on it, and the selection bias that each of us have in recognizing that, okay, we see a certain population. I was going to say, for me, the strategy that people develop to help with these sorts of things is absolutely the issue. I had a online consult today where she doesn't have diastasis, she's got incontinence and pelvic organ prolapse, and for her strategy has been to flare the ribs out and suck up using her breathing, and that's how she's trying to stop leaking. Now, that's rather difficult to do high-level exercise if that's the strategy that you're depending on, to stop incontinence from occurring, for example. So for me, whether you have a diastasis or not, I'm much more interested in, well, what are you doing with it? How are you developing the pressure that you need to provide this? We know that core stability really is about pressure, right? Been in the literature for ages. It's about intra-abdominal pressure. I was reading some biomechanical studies just the other day which talked about unloading spinal joints and providing support with increasing levels of intra-abdominal pressure. Like, this stuff exists. How are you developing that pressure? And, pressure in a fluid-filled system is equally exerted in all directions. Therefore, it's the stiffness of the container that is more important in how you're going to direct that pressure, because pressure technically is exerted in all directions equally. So exactly what you're seeing on ultrasound, to me, is, well, whether you have a diastasis or not, looking for that descending bladder, not able to meet the pressure using your pelvic floor, excessive amounts of pressure from above being developed through whatever strategy you have, using ultrasound imaging for that, I think is really cool. And yeah, I won't ever challenge you on doing that. No, I think if you said, well, everyone that I see with a diastasis, that's what they're doing, therefore everybody with a diastasis is doing that, I'll have a quiet word with you. But you're not saying that. So.
No.
Yeah.
I'm trying to think what else I was going to say to you. What are you finding in terms of physiotherapy in Australia? Do you find that everyone's doing the same approach, or do you find that it's quite varied from therapist to therapist? And is that an issue?
I think it's pretty variable. I don't actually know what a lot of people are doing. I think on the whole, there's probably still quite a lot of confusion. I think we have some people who are very much in the crook lying, getting the deep abdominals, activating, adding a little bit of load, like a very conservative approach. We have another group who are using much more of a curl up, do lots of crunches. That seems to make our patients better, that kind of approach. I think most physios use more. I think people are moving more into functional exercise these days, and certainly Anthony has had a big influence on what happens in Australia. But I do think, I think there's a lot of variability, and perhaps that's part of the problem. It'll be interesting actually, Grainne, as I do the masters, because we will cover diastasis, and I will be obviously poking the bear a lot and asking a lot of questions. But I'm intrigued to see actually what happens, what people are doing nationally, and what is recommended through the university courses, because I think just in conversations online, I think there's a huge amount of variability. I don't think there's a lot of agreement. And then certainly with conversations in groups in the States, they're doing completely different stuff, I think, to what a lot of us do here as well. I don't know, Anthony, what do you reckon?
I think being in Australia, my feeling is that lots of women's health physios, lots of pelvic floor therapists are still really concerned about the pelvic floor dysfunction, and will check that and will integrate pelvic floor with abdominal function, whatever that means, and breathing. I think if we look at those three things, which is breathing, abdominal wall control, and pelvic floor function, I would say they're the three main things that most physios, I would say around the world, tend to focus on. What that looks like in terms of an exercise program goes from bent knee fallouts, and you can't graduate from bent knee fallouts until you can do them the way that I'm happy with, all the way through to, you're breathing, you've got an abdominal wall, you've got a pelvic floor, let's go. It's very, very variable. I personally am a conservative physio. I know it doesn't sound like it. I know that people laugh whenever I say it, but I stick by my guidelines and the principles that I use, which is why I can take Lisa, and we're talking about Lisa because she's given me permission to talk about her case. I would take Lisa through some really scary stuff for some therapists, and other therapists, they're like, well, of course you did, because that's what I would do too. But she's ready for that, right? And then there are other people, it's like, you know what? You are at a crunch, and I'm going to let you lift up one leg as well. And that's it, because that's all I can watch you do without, breaking whatever standards that I want to keep in place. I can sense that you're bearing down. I can, I can't tell for sure, but you need to check with a women's health physio, but I think you have a bearing down strategy to develop your stability. And that really is more important to me than your diastasis and where it's at, because one of the fears of people with diastasis is that they do develop pelvic floor dysfunction if they don't have it. And, they've had people who say, oh, my diastasis is better and now I leak. So
I think that comes back. That's a really valid point, though, Anthony, because when you're dealing with diastasis, sorry, I say diastasis, whatever. Grainne obviously is a pelvic health physio, and she uses real-time ultrasound, but she also does internal examinations. Anthony and I are musculoskeletal physiotherapists, so we pretty much, well, I don't know about you, Anthony, but just about everyone that I see will see a pelvic health physiotherapist. And I do some internal examinations now, but that's kind of part of that picture. I think all of us want to know what is going on internally, and I think without that knowledge, it's very hard to push people to that next level in terms of their rehabilitation. So what do you think, Grainne, about pelvic floor physiotherapy intervention, pelvic floor physiotherapists and their involvement with diastasis?
I think it's key, exactly for the reason, because otherwise we are guessing what's happening at the pelvic floor and you just don't know. And what Anthony's highlighted earlier is this is not necessarily a strategy at the pelvic floor that they've developed as a result of diastasis. It could have been a strategy they had anyway that needed addressed, but that the whole picture of it, I suppose, alongside what's going on at the abdominal wall, needs to be improved. So I'm a huge fan of, I would always generally assess someone pelvic floor wise when I'm treating diastasis, and I agree that most anyone who is MSK and treating diastasis probably should be linking in with a pelvic floor physio. And it's interesting because the issue that we have currently is that there's no guidelines for diastasis. So I'll be interested to hear an update from your masters, Marika, to see what they are putting out there. But we are currently, as you may have heard that Tom Goom and Emma Brockwell, if you're aware of them in the UK, we are currently writing, I suppose, the first return to running postnatal guideline, and Anthony, you've had a wee sneak preview of the first draft, but we are making sure that we're getting diastasis in there because it tends to be the missing link. So the focus on these guidelines is pelvic health, and usually pelvic health guidelines stick very much to pelvic health. So we're trying to, I suppose, highlight. It's not to say that everybody returning to running will have diastasis, or that anyone returning to running who may have pelvic floor dysfunction will have diastasis that will have caused it, but it's more to put that out there to the sporting profession that are going to be reading this, because it's most likely not going to be strictly pelvic health physiotherapists accessing these guidelines. It's going to be the therapists dealing with them. So we need to be opening up those channels of communication, and we've actually highlighted that women should all have an evaluation before returning to running postnatal, and that should include a pelvic health physiotherapist, and it's that co-working between pelvic health and MSK community. So hopefully these will open a dialogue. Hopefully, we'll see. I have a draft 2 coming your way soon, Anthony. Yeah, I'll send them to you too, Marika. I will. Yeah,
I'm really interested in that. No,
because we want as much peer reviewing.
That's awesome. I had a client recently who was she's a runner. She runs marathons, and she's sort of 7 years postnatal. I think I was chatting to you, Anthony, and she had pretty significant diastasis, but was kind of cracking on as you do as a mum, because she had 3 children. And but it was amazing because I just basically gave her lots of abdominal strengthening exercises, but in more upright positions related to running. And I saw her a couple of months later, and she was hitting these PBs, and it was just so exciting. It was exciting for her, but it was exciting for me too, just to see that, you know, that strength is just so important for running. The abdominal wall strength is actually, functionally, it's really important.
Huge. And the biggest thing for me postnatally is the culture, which I'm sure you're experiencing. You're in Australia, so it's all beach bodies everywhere, but it's social media and the snapback are working upon this community, because women are, I suppose, jumping into exercise and high level exercise too soon, and this does not facilitate the rehab. I'm not completely cautious, we've talked about that, but it has to be the right element and the right grading of exercise and the right progression. But one thing that really gets to me is, I'm sure it happens everywhere, we have a lot of local classes and boot camps which advertise as postnatal friendly, diastasis friendly, and oh my goodness, they are not. But that's what patients are seeing, that's what these women are accessing, and if they see a flyer that says, but this is tailored to postnatal, where are the I suppose the watchdogs and the bodies that are kind of regulating these things?
We definitely have a lot of that.
Good, it's not just us.
I had a client who came to see me for a second pregnancy, and she had 12 months of really significant low back pain after her first baby. She was absolutely fine. She went to, I think she was 8 weeks postnatal, hill sprint, burpees, star jumps, planks, and she developed such significant pain. It took her almost a year to recover.
All of which are not bad exercises. Just probably not appropriate for her.
Yeah. At some point in the rehabilitation program, I have no problem with planks and burpees. Yeah. I mean, planks are boring ads. I don't know why anyone would want to do them, but if that's what you want to do, if that excites you, I'm more than happy to get you back to that. But I don't think it's a great exercise to kick off your postnatal rehab.
Yeah.
But you know what's really interesting is that because I'm using the ultrasound, and because we live in a culture where when women are looking up, they're maybe starting to get the message of stay away from crunches, never do crunches again. when I see a lot of these women, and the research backs it up, is that where the diastasis is largest, there's been quite significant atrophy at the rectus abdominis muscle belly, and that's a huge issue because that affects our strength. We're supposed to have muscle bulk there, so I think as physiotherapists we have to know when to start to reintegrate that and how to reintegrate it, and exactly kind of echoing what you've said already, Anthony. But it just to make the point that yes, we're seeing that I suppose muscle waste in there, and that's an issue. That's an issue, so we need to be addressing it.
And yet again, my favorite thing is, restricting activity in the hopes of saving a vagina is not holistic women's health. That's just the bottom line,
Yeah, I know, but it's really, it's really hard though, because that's where I think pelvic floor evaluation coming in and reducing that fear and giving them the strategies to know how they are recruiting right down there, so that then you're taking that element of fear away. So I think that's why that's important, because you can reassure them without blindly reassuring them.
Yeah.
And I think it's offering people a pathway though, isn't it, Grainne? Like, if you see someone once or twice and then send them on their way and say, yeah, you're fine, that's very different to, okay, so this is our plan for the first 4 weeks. Let's see how you go with these exercises. Okay, we need to step you up to that next level. Okay, so you were talking about, muscle atrophy. What's the process of getting that hypertrophy and, bulking up those tissues and getting them functional strength? And I don't know that a lot of people are getting the mid to late stage rehabilitation of their abdominal wall, which is the stuff I love doing, and I'm pretty sure you guys do as well, is actually taking them through that process. And I think for a lot of people, it's kind of that early, 6 weeks of postnatal Pilates, and then that's it.
Mm-hmm. Yeah. I think women have to get back to their meaningful sport, and that's my biggest thing. Get them back to the thing they love, because having a baby is a huge life-changing event, and it changes significantly for the mother. So if you can give her that headspace of the activity she enjoys, and so that you're given elements of life that haven't changed, I think that's key, because that's what we should do, rather than, oh well, I've had a baby and now I can't do that anymore. We just live in a can't do culture, and that's where physios need to be changing their voice, because these women are finding other professionals, because other professionals are saying, yeah, I'll get you back to that, and that's where we're losing. So we need to be using the expertise, the knowledge, the skills we have, because we can, I suppose, more holistically provide them with the strategies to get back to where they want to be, and we need to be doing that. But you talked about a pathway there too, and I do still think that while I'm big pro conservative management, but I'm realistic to know that similarly to gynae conditions that I treat, physiotherapy is not going to be the answer for everyone, and I do think we need to have better links and pathways for getting these patients that don't respond conservatively or don't achieve their goals, because I might be happy with someone's function, but they're not happy with their outcome, in terms of it could be more to do with the aesthetics or more to do with how they feel. So I think we need to be better at having more of a voice in the surgical field, and the fact that a lot of surgeons don't really rate physiotherapy in the process is eye-opening. And my biggest thing that I want to raise is that we should be involved in the pre and postnatal rehab of these clients, because the surgeons that I interviewed, one of them said that it was 8-week recovery for a full rectus abdominis plication with tummy tuck, and that's major surgery. So I actually clarified, could that person go back to CrossFit at 8 weeks post op, and they said yes. We are the rehabilitation experts that need to be guiding that. So we need to be making our mark to show that we know how to progress these clients safely and to safeguard the integrity of that repair. And so I think we have more to do there, and establishing links and making our mark.
Very, very valid points.
I was wondering, in terms of how your patients, the fears that they're dealing with, and the language. Can we talk about the fear-based language specifically? Like, what are some of the things that you're hearing from your clients that are concerning in terms of the language that they're using and the things that they're reading? Do you have any insights on that sort of thing? Because that is going to affect how they see their progress towards what they're going back to, what they want to do, and if we have such a negative view, you said a lot of the times that we physios often do that, right? We often say you can't, So just trying to tie in all those themes in then with the language. Like, I mean, my belief is that what we believe as physios and as therapists, health professionals, fitness professionals, what we believe then comes out in our words. What are some of the things that clients should be looking out for in their therapist's language, in things that they read, and what things should they be doing to, I suppose, inoculate themselves even against?
Well, first of all, the therapist shouldn't be just solely focusing on the gap. I always think that's a real warning sign that if you have someone obsessing over the gap and that's the only marker they take, you need to find another therapist. They should be talking more holistically and finding out more about you and what you want to do. I always think that there shouldn't be, kind of what we covered, there shouldn't be the idea of, oh, you can't go back to that. You're going to be doing Pilates for the rest of your life and basic entry-level Pilates for the rest of your life. That's a warning sign. And also therapists who come out with things like, oh, that's because I get a lot of women who come in and say, I know, I'm just so annoyed. I was just so fit beforehand and that's why I've got diastasis. And that kind of creates this bad message that being fit is a risk factor and a negative thing when we know that exercise and fitness is good for everything. So they're probably going to get diastasis anyway. But it's that sort of fear-inducing language that even makes the client think that this is something they've done to themselves. Nearly, I get a lot of people like, oh, if I didn't, I was getting up on that sit-up action all through my pregnancy, I give myself a diastasis. So I think that we need to be mindful that we're accessing therapists who, one, seem to understand about diastasis and that they seem to have an understanding of what the literature and what other health professionals are saying out there, and that it's not prescriptive and it's not one size fits all, and that they do the same thing with every client. It should be bespoke and tailored and individualized. And it should encompass more than just exercise within that session. So for me, diastasis, to address it properly, you have to think of that lady and her activities of daily living. So you have to give her strategies for lifting the baby, putting car seats into the thing. You're giving her just good technique of doing that, but also things like constipation. If someone's significantly constipated, that's a huge exertion on the abdominal wall. And so if you can improve that, I think that's a huge element of improving their overall health and well-being in terms of diastasis as well. I'm not so sure how much you go into the nutrition side of things. I'm not a nutritionist and I don't have the qualifications in it, so I don't tend to touch so much. I like the idea of eating clean and yes, drinking your water and getting your fruit and veg, but I would often signpost people if I think they need advice on nutrition. But what in terms of physio and in Australia happens?
I always ask about constipation and bloating,
bloating.
and then I refer on. Yeah, because I definitely have some who have lots of bloating. And then when I ask them a little bit more, maybe they've got some IBS or some other things, which is totally just not in my scope. But I do think that internal pressure going out may well be, contributing to, not only the aesthetics of the abdominal wall, but maybe some pressure on the linea alba. So yeah, that's kind of my thing.
Yeah, and it's the same thing. I don't pretend to be nutritionally what's the word? Proficient? Look, I'm not trained in nutrition, so I ask the simple things: constipation, bloating. It's interesting, the whole EDS thing, digestive function, hypermobility, Crohn's disease. There's quite a few different little interesting bits and pieces there. I'll ask them about if they've noticed any correlation, but certainly if there's anything that pops up, I handball that out to somebody who does do more of that stuff. But even touching on things like constipation, taking care of the basics is an important thing. Dealing with the constipation, dealing with the hay fever, dealing with chronic cough, sneeze. These little things do make a difference. But also, making sure that people, I often say that, if you told a physio that everywhere within a certain room was safe to exercise, most physios will go stand in the middle of the room and exercise. They'd never really go to the edges comfortably, most, physios. Whereas I'm like, oh, I want to see how close to the edge I can go. And
Oh,
we know Well, we know from the research that you need at least 70% of your 1RM to get actual change in your muscle strength, true muscle strength, not just neurological. So you have to kind of push, you know. It's not, I don't know, doing little itty bitty things isn't really going to help people in the long run.
I like what. Oh, sorry. I was
You
just going to say, I like what you're saying about the self-blame side of things, because I think that's really important to address as well in terms of, like, I'll ask people about their perception of their diastasis, and you know, you're talking about the story, and I think it's really, really important, because I definitely have some clients who will come and say, oh my god, I did this exercise in pregnancy, or maybe I didn't eat as well as I could have, and there can be so much self-blame around that, and just letting them know that, you know what, there's probably nothing that you did that actually contributed to this. It's, you know, it's a lot of genetics.
Yeah.
You got pregnant.
And the fact that it's a normal part of growing a baby. But women have so much self-blame, and I think that can actually limit their rehabilitation.
Totally. It's the same as every other condition we treat. The whole biopsychosocial approach is important. But it's even like just, I don't know, it's all those beliefs already that's affecting their self-confidence and self-efficacy, and you're just channeling into that whole circle, and it's spiraling out of control. So it's given them chance. But similarly to, I suppose, other pelvic health conditions, diastasis in many ways is still quite taboo, in the sense that women will try to hide it. So they're wearing suitable, I suppose, underwear and clothes to hide it. They haven't told their friends they've got it. Chances are their friends have it too. Do you know what I mean? So women are suffering in silence with this, and coming to us and the outreach, and hopefully us at some stage, looking for help. And they're nearly that relieved that you know it, or you've seen other people with it. You know, that you can see that element of, okay, and like other young people, I'm like, yes, you know, and suddenly you can see the fear lifting. But that's why I think the likes of this and this sort of platform here is key, because most women find me via social media, because they're not telling other people about it. They're not accessing me through their healthcare professionals, because they go to their GP and their GP tells them they need surgery after they've finished their family. Which is, on another point, I'm actually currently doing as part of my public sector job, I'm doing an audit involving, we've sent a questionnaire out to all the GPs in my trust to ask them what different questions about what they understand about pelvic health. That includes things like whether we treat diastasis and things. And the answers we're getting back, it's so interesting. They do not understand our job. We're like the Chandler Bing of physiotherapy. Nobody knows what we go to work to do. And I think that we need to change that.
Or something.
But I will update you on what the outcome of that survey is, because I think it gives us an indication of, I'm sure it's the same in all areas around the world, but it gives us an idea of what we need to be increasing awareness to our medical professionals about what we do. And what annoys me is that a client might go to their GP, and the GP has said, you'll need surgery after you finish the family. And then they come and find me, and I'm like, no, well, we can do conservative rehab, but the GP's here. I'm here. They believe this more. The GP knows more and knows that they need surgery. I don't realize they don't need surgery. You know, that's what we're living against. So I think we need to be getting the GPs with the right information, so that they can be our voice as well.
I think that's really true. And I get women in pregnancy. Sorry, Anthony, you had to talk at the same time. So I see a lot of women in my pregnancy classes, and also through my online program, but just trying to let them know about diastasis through their pregnancy, let them know what is normal, what is not, what are their options postnatally, how can they screen it themselves postnatally, trying to educate women, but without scaring the shit out of them, excuse the language. But I want to get them really early in the story, so that I can almost like imprint on them what I think is relevant. But I think it's harder when we get people much further down the track, because they've already been Googling, because they've discovered there's this problem. And what do? You jump online and you start Googling, and then you get exposed to all and sundry, really.
Yeah, and what I want to also say is that for anyone listening to this, if you have diastasis, don't wait until you finish the family. There's that common belief of, oh, I've got diastasis, I maybe need to go get physio, but I'm going to have a couple more kids, so I'll just ride it out. I'm like, come in between. We can do so much. We can prevent that progressing. And then you're not getting them at the stage 5-6 years down the line when they've got that when their story's much longer, when they have a lot more elements to their story. So let's get it early and let's access help earlier.
Yeah, and like if you're not doing anything for it as well, we're going to have to deal with the fact that there's significant muscle atrophy as well, you know, like we need to get you stronger. I had a woman just the other day, you know, and she was really concerned about her diastasis. She was concerned about how her tummy looked. And part of it was, okay, well, you need to do some exercise for this, there's no doubt, because, you know, you need to have a little bit more strength to do the things you want to do. And then some of it is like, look, I'm a physio, so this is skin and fat. This has nothing to do with me in terms of the diastasis. I can certainly give you exercises to help you get fitter, but this is going to move forwards with your diastasis and some of the look that you don't like. And for her, it was about the look. It wasn't about the function at all. It was about the look. You know, it was like, if it's about the look, I'm not going to make any promises. But from what I can see, there's certainly things that we can do, and why don't we see how we go with that? And you focus on getting your nutrition right, you focus on getting your exercise in, you focus on getting enough sleep and enough rest, because we know that mothers need that sort of thing. And then let's see how we go from there.
It's funny because as some women progress, even though the focus can very much be on the aesthetics and the skin, we as physiotherapists can make some change in the actual pendular look of it. So some women find that they're actually happier when actually I'm wearing clothes that I haven't worn in years. So then suddenly the aesthetic component changes for them. They're happy enough with what their body looks like when they're looking at it skin to skin, but they're happy enough that they can dress it better, if you know what I mean. So that's a huge element. And I think that's why everybody should access conservative rehabilitation first, no matter what stage they go through, and whether they follow that on with a surgical consult, because then they're more informed for the postnatal rehab, and then hopefully access postnatal rehab, because at the minute there's a whole population out there getting surgery and not getting access to postnatal rehab, which is a huge issue. We get how many months rehab for ACL?
So you mean post-surgical rehab?
So sorry, post-surgical rehab. Yes, yeah. Sorry. But I laughed because I was like, somebody has an ACL repair and they get prescribed or sent to physiotherapy for months of rehabilitation, and people go undergo recti application, and it's just back to CrossFit at 8 weeks.
Yeah, that's mental, isn't it?
Yeah.
We will probably wrap it up pretty soon, but I just wanted to ask Grainne, when you have a new client who comes to see you who has some tummy muscle separation, how do you set the expectations for them, or what's the prognosis that you would give your client? I know it would be variable. I'm guessing you don't promise everyone a six-pack in 6 months.
No, and to be honest, I very much highlight that I usually tell people that there's a lot of there's quite an absence of research in this area, but that as physiotherapists, we're well placed to guide exercise progression. So when we assess them and evaluate that, you know, what their, I suppose, deficits or what things are highlighting, because I would very much from the offset educate them that a little bit of separation is normal, but highlight that we want to make sure the function of the abdominal wall is restored. And so it's not just about the gap. So once we identify what they're doing well and maybe what they're not doing so well, I suppose offer them that I can, I suppose, facilitate them in improving functional aspects. Hopefully, because it depends on if they are able to transfer load or if we can improve their load transfer across the lineal. But with some people, they may not be able to achieve that, and they may be quite a clear-cut surgical candidate. So that's important to highlight from quite early on, so that you're not given false expectations. But in terms of the aesthetics, I would say that some people do get an improvement in the aesthetical component in terms of the support of the tummy, but it really depends, and it depends on how compliant someone is, because diastasis is not a quick fix in terms of rehab, and it does involve dedication, and it can be painfully slow and boring, but that it depends on if the client wants to buy into that. The way I work is that I see people very spread out. I don't see them often at all. I usually see people, assess them, give them a rehab program, send them away for weeks doing it before I want to see them again, because I want to see, did they have a response? and then progress that load. So it's not something that they're running forward and back to me. It's something that very much they take ownership for. And that's my biggest thing, is giving them the ownership and giving them the tools to know what they need to be doing and what not to be doing, and decreasing the fear. So even if, you know, people have been advised not to do something, I'm like, don't worry if you forget and you're going through life's mental life, 3 young kids. If you're just grabbing and going and doing anything and not thinking about how you're doing things, don't worry about that. You're not going to undo all your work and progress. And that's a huge element of reducing the fear, because women can work and do the rehab and then decide that they got up the wrong way or did something, and suddenly they have this meltdown where they think they've undone everything, they're back to square one, and they're not. They're fine. I always talk about, I want to increase the amount of things that are good to help progress your diastasis and decrease the amount of things that go against it, but we're never going to completely eliminate them. We're just trying to change the balance. So that's the way I would bring it to them, and then I give them ownership of that balance and see how they go.
I think that's fantastic. And I love that you mentioned surgery and the fact that it's not a failure. For some people, it's absolutely a necessity. And clients that I've had who've had it done, it's changed their world, and they're so glad they had it done. Yeah. And they felt in me afterwards how much, and actually weirdly, even though for a lot of women, it's the aesthetics that got them in, afterwards, they don't talk about, for me, I don't know whether you guys agree, but they don't go, oh my gosh, I'm so glad that my tummy's flat now. They actually come out and go, oh my gosh, I was getting the pram in and out of the car, and I just felt like there was this connection. I feel so much stronger. And they actually post-surgery will talk more about the strength and function rather than the aesthetics, even though I think for a lot of women, it might be the aesthetics that is the tipping point for them going in. Which I just find interesting.
Yeah. I think that the two are so correlated in many degrees, because I think that possibly that disconnect and lack of function then makes it harder for them to deal with the aesthetics, because, you know what I mean, they could become so separated from that area because it doesn't do its functional job right and it doesn't look how they remember it, and it's a huge component. So I think fixing either or can have an influence on the other.
Yeah, absolutely, I agree, actually. And there's quite a few ladies who are definitely heading towards surgery, and they got so much stronger. There's still that little bit of a pooch, and they've just said, you know what, I'm actually okay with that, because I can do all the things I want to do. It looks a little bit better, you know, in profile. I'm okay with that.
Totally.
Yeah, and that brings up even more issues, you know, things like identity. Some, you know, it's going to you know, just the whole concept of I've been defined by diastasis. I'm thinking of people like Lisa, Brianna Battles, you know, where this has been a big part of their life. The question of identity and post-surgery, what that's going to be like for them is going to be really, really interesting. And, you know, I've been a part of both of their journeys. But, you know, identity is a big thing for lots of different people. And you know, whether you identify with the stories that you tell yourself and self-blaming. Coles doesn't exist in this shopping centre. Well, the IGA is there. The Coles is outside of town. Yeah. Thanks. Sorry. Directions. So
I should have a sign up. I am not the center management, you know.
So being able to be a part of Brianna and Lisa's journey has been interesting, but certainly that idea of identity is really important. And so whether you're identifying with the stories that you're telling yourself, and like what you were saying, you know, the self-blame type of stories, or when people develop something, they go through and they think about absolutely everything that they should have done differently to maybe have prevented that. I think, you know, exploring that is really important. And, you know, all of this comes back to the same things that we're doing in physio, in healthcare, in pain science, for example. You know, those danger messages, the safety in me messages, DIMS and SIMS, if we're going to use the NOI type stuff. acknowledging the psychological implications of what's going on, because everybody focuses on the anatomy, which is biological, of course, but there's a psychological component and then the sociological component, which, the whole pancake idea of a person with, I don't know who said it, but anyway, I use it these days, where pancakes have flour, eggs, and water, absolutely. And we cut into the pancake and we never say, oh, here's the egg part of the problem, right? Oh, here's the eggs in the pancake. Like, a person is a biopsychosocial presentation, and the amount could be different, it could be the same, it doesn't really matter, but you can never separate that out. So, just talking about, just thinking about it, and as a biopsychosocial approach to diastasis is important. I do want to sum up just real quickly. It felt like we got together, we grabbed a portable drink, like, a bottle of water, a travel coffee, and we went walking through the countryside looking at all the different things that we could look at. Some key points maybe that we could tease out. Physios have a lot to offer, and we don't do ourselves any favor in promoting ourselves, because we aren't, well, first of all, legally, we can't make really extravagant claims. But secondly, we're not naturally marketers. We're health professionals. So we do suffer from that. So physios have a lot to offer. There's a lot of fear-based messaging going on. There's a lot of beliefs out there. I would say beliefs and myths about diastasis. And one of the great points that I thought you made, Grainne, was looking at getting help even if you haven't finished having your family yet. I think that was a great point. Knowing what's happening at the pelvic floor level, either externally or internally, but at least having a holistic approach. The breathing, abdominal wall, pelvic floor, whole body assessment. We spoke on strength and the whole idea of you can't have too little, or you shouldn't have too little exercise. You've got to have enough exercise. We talked about whether diastasis and pelvic floor are related. We talked about, what else have we done? We've talked about a lot of things. Are there anything else that you'd like to add in the little sum up? Elaine's been taking notes, so we're going to have great show notes. Is there anything that you really wanted to hit home, Grainne?
Well, actually, when you were talking there about, yes, highlighting not to wait until you finish a family, what I want to make a point of, and I don't know whether you find this as well, but any women who I've had, when they haven't finished a family, say they've had a significant diastasis, they've been on that journey, they've followed rehabilitation, they've taken the plunge, because it's really fearful for them to go back into that, situation that, I suppose, caused them their diastasis in the first place. So to go back to a pregnancy can be quite a fear-inducing thing too, because they feel that they're going to undo all their good work. But I can hands down say that anyone who I've taken through rehabilitation never gets diastasis to the same degree again, and they recover quicker because they're informed and they know what to do and they know how to access help. And so that's something that should be really empowering to anyone listening, that it's not a case that you're going to undo it all or step back, that actually you're stronger, you're fitter, you're actually going into that pregnancy in a better situation. So
fantastic.
I 100% agree with that. And I find my clients will say they recover so much faster second time around.
Yeah. Information is power, right? So just having somebody more informed is so much more helpful. All right. Is there anything else to add?
Is Grainne still there? She's frozen on my screen. Oh, you are there.
Now. Sorry, I'm back. I froze. Yes, I'm back. Sorry.
Yeah. She was just pretending to be a preteen girl watching the movie Frozen. So.
Do you have any closing remarks, Grainne?
No, I would like to say thank you, Marika and Anthony, for the opportunity, because again, any sort of opportunity to give physiotherapy a voice and to highlight what we can offer and to get good, I suppose, evidence-informed information out there for the evidence that exists, and hopefully in the future we'll be adding to that. And Marika, I look to hear what you'll be adding once you get this master's over you. You'll get a wee bug for doing something too, I know, rightly. But I want to keep in contact, and hopefully I'm excited to be taking Anthony's course when he comes to Belfast in February. I am a wee bit interested and also a wee bit fearful of the fact that it may totally explode my head with what's happening in terms of diastasis, and it may give me new elements. But we should revisit this talk at some stage and discuss where I'm at now.
I think we should do this as an annual thing.
Yeah.
How can people find you if they're in Northern Ireland?
I am available via email to info@absolute.physio. I'm on social media, Twitter handles, Facebook handles, absolute.physio. And what Anthony found out by default, actually, I also go under the alias Diastasis.physio. So I've got social media pages with that. So Anthony and I were discussing recently a discussion on social media. I thought he knew that was me, that I had tagged him and asked a question, and he was just there like, I don't even know who that is. And I was like, that's me.
So we were on a
he
Zoom
didn't
call.
say anything bad.
We were on a Zoom call and we were talking about diastasis stuff, and then she goes, "Oh, I meant to get back to that post," and I'm like, "Yeah, I don't know who diastasis.physio is." She goes, "It's me."
So that's
a couple of hours out of
Belfast
where
and Dublin.
A couple of hours out of Belfast.
Yeah. But basically probably 2 hours from Belfast and 2 hours from Dublin. I'm quite central. I'm very borderline with Ireland, but I'm still in Northern Ireland.
Okay, cool. So if anyone needs some treatment of their diastasis and they're in Ireland or Northern Ireland, or Scotland or England, anywhere. And do you do anything online,
contact her.
like start consults?
That's something we've actually been talking about starting here in our clinic. So funny, because I've seen the likes of, I don't know whether you do them, Marika, but I know Anthony does them. That anyone who wants to contact for diastasis, just get in touch, because I'm a huge fan of even finding someone, a suitable therapist local to them, and helping them source someone who I know is informed, or just giving them good information that may help them without even seeing them. So yeah, anyone who's in any way wanting to find out more about diastasis, don't be afraid to get in contact.
Well, thank you very much for being a part of the show. We will talk again, no doubt. Hey, and when I'm in Belfast, maybe we have to record something real quick, and maybe you can record your thoughts with me, and we'll try to get Marika on as well. And yeah, that should be fun. I'm looking forward to it, actually. And yeah, maybe you can bring a couple of real difficult ones so that the class can see it. That'll be really fun.
Yeah, I'll have a wee think with that. I'll see if we can access someone and get them up as a case study.
Yeah,
definitely.
Yeah.
Awesome. Well, thank you very much.
Thank you so much.
And we'll chat soon. Bye.
Okay, thank you guys. Bye.
Well, that's it for this episode. Please be sure to hit like if you enjoyed this episode, and leave any comments or questions below, because we'd really love to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified of when we release a new episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.